Hey, I'm back. The bridge is back. I'm back. As I've mentioned, I want to discuss the New York Health Cares Act. So last Saturday, I believe there was a meeting at the Will Library, hosted by Shelley Mayer and a panel of, I believe there was a doctor, a nurse, Richard Gottfried, who is a retired assemblyman, Shelley Mayer, and I think a second doctor. I don't have the names; they're unimportant for this broadcast or podcast. But I wanted to talk about the New York Health Cares Act and what it means for you and what it means for me. It's listed as Assembly Bill 7897 or Senate Bill 7590. You can look those up if you'd like to get your own read on it. By all means, I'm no expert. I just want to give you my take on what I have gleaned from reading the bill, looking at some of the information that was presented as available. I'm going to kind of adjust this up a bit. Some of the information that was available. So the bill starts off, it is the intent of the legislature to create the New York Health Cares Program to provide a universal single-payer health plan for every resident of the state, funded by broad-based revenue based on ability to pay. The legislature intends that federal waivers and approvals be sought where they will improve the administration of the New York Health Cares Program. But the legislature intends that the program be implemented even in the absence of such waivers or approvals. So basically, we'll break that down a little bit. Um, this is a plan to cover every New Yorker, single payer, um, every resident of the state. So that means as soon as you become a resident, and I assume if you're here and you're homeless, you're a resident. If you've entered the state, if you're a recent immigrant, if you're a migrant, and frankly, I'm not sure of the difference at this stage, but if you're here with legal documents, or you're here without any legal documents, you're a refugee, you're covered. Um, and it's being paid by broad-based revenue. We'll get to that in a minute. And the legislature intends that the federal waivers and approvals be sought. So they're going to look to use federal Medicaid, Medicare funds that would normally come in to fund this program. And if they can't get the waivers, the New York Health Cares Act goes forward. Now, a caveat: this has been on the books in some form or another since 1992. This bill has not been approved since 1992. The new bill has some carve outs which make it more palatable to unions. Basically, it makes it illegal for any health insurance company to operate in New York and offer the same program that the New York State Health Cares Act has, same program and services. And I'll get to that. Let's see, where is that? Uh, an insurer is authorized to provide coverage under the law, or any health maintenance organization certified under this chapter may, if otherwise authorized, offer benefits that do not cover any service for which coverage is offered to individuals under the program, but may not offer benefits that cover any service for which this coverage is offered to individuals under the program, provided, however, that this subdivision shall not prohibit A, the offering of any benefits to or for individuals, including their families, who are employed or self-employed in the state, but who are not residents of the state. Basically, if you're not a resident of the state, but you're employed by the state and you live in New Jersey, for instance. Um, During the implementation period, to individuals who are enrolled or may enroll as members of the program, the offering or retirees health benefits. Break it down simply. If you have union benefits right now, if you have employer-sponsored benefits, those all go away if you're a resident of New York State. I did ask Richard Gottfried at the meeting, probably attended by about 50 people. What happens if, let's say, I work in Connecticut and my employer gives me insurance in Connecticut, but I reside in New York? He said your employer would need to pay into the New York plan, and you would only be allowed to have the New York insurance. And follow-up question, well, what if my employer doesn't want to? Then I would be responsible for the entire coverage. Let's take a look at the revenue for the program. The revenue for the program shall come from two taxes. First, there should be a progressively graduated tax on all payroll and self-employed income paid by employers, employees, and self-employed individuals. Second, there shall be a progressively graduated tax on taxable income, such as interest, dividends, and capital gains not subject to the payroll tax. Income in the brackets below $25,000 per year shall be exempt from taxes, provided that for individuals enrolled in Medicare as defined by the program. Income in the brackets below $50,000 per year shall be exempt from taxes. So if you're on Medicare, you don't pay taxes on your first $50,000. If you're not on Medicare, let's see, is that Medicare or Medicaid? Let me go back there. Medicare. So if you're on Medicare, you're exempt for the first 50,000. If you're not on Medicare, you're exempt for the first 25,000. Higher brackets of income subject to the taxes shall be assessed at higher marginal rates than the lower brackets. The taxes shall be set at levels anticipated to produce sufficient revenue to finance the program, to be scaled up as enrollment grows, taking into consideration anticipated federal revenues available for the program. Now, we spoke about that. They may or may not come. If they don't get the waivers, there's no anticipated federal revenues. Provision shall be made for state residents who are employed out of state and non-residents who are employed in the state, including those employed less than full-time. So that basically means if you're, as I said before, if you're employed out of state, but you're a state resident and your employer doesn't want to pay your pay, that's the provision. Each public employer, as defined by Section 201 of the Civil Service Law, shall pay a percentage of the payroll tax for each of its employees. So this percentage that's outlined here is only covered by public employees. At the equal to the least greater of the percentage of the cost of the employer's health care paid by the employer as of January 1st, immediately following the preceding date on which this section becomes law, or the greater percentage provided by a collective bargaining, or 80%. Let's assume it's going to be 80%. Your employer will pay 80% if you're a public employee. It's not really spelled out. If you're not a public employee, there is a percentage that your employer will pay, and there is a percentage that you will pay. Plus, you'll be taxed at all interest revenue, rental revenue, all of those things that are normally taxed but are not payroll taxes. So I wanted to go over the cost a little bit. So there was during the meeting, they kept referring to a study by the RAND Corporation, and the RAND Corporation put together key findings. They put together a full study, but I'm just going to read some of the key findings. And this was 2018, so let's remember what the cost of goods were in 2018 versus 2020 versus 2024. The author estimates the total healthcare spending under the New York Health Cares Act could be slightly lower than the spending under the status quo. What they mean by that is the spending under the status quo is what everybody spends on healthcare. You, me, my health insurance, my retirement benefits, anything else rolled into that. If we're all together as a group and have no choice in our healthcare, it would be slightly lower. And the next phrase will tell us what slightly lower means. Spending would be similar in 2022, remember, to 2018 study. So we don't have inflation rates in here, and 3% lower by 2031. So it would be similar In 2018, it would be similar to what the spending is in 2022. And we know where prices went from 2018 to 2022. And we'd have to wait till 2031 for there to be a 3% reduction, with the 10-year cumulative net savings being about 2% if administrative costs and growth in the provider payments are reduced. So they're expecting provider payments to be reduced. They're expecting doctors, hospitals, nurses, and medical providers to say, you know what? I'm going to be a good guy. I got to reduce my costs. So let's figure out how we do that reduced costs. I'm going to just, there's so here's part of the bill. It says it is the policy of the state to encourage cooperative, collaborative, and integrative arrangements among healthcare providers who might otherwise be competitors. So basically, they're saying, look, we don't want you to we want you to work together to bring the cost down, and we don't want to reward anybody for being a better doctor, or we're just going to kind of put you all in this one bucket. We're going to tell you what to pay, and you're not going to compete on that. Remember, there's no private payer in here. I can't determine that I want to go to my doctor and I want to say, look, now, plastic surgery, I guess items that are not normal healthcare items that your insurance doesn't cover anyway. They're not part of this bill. So if I want to go and I want to take care of my double chin, I'd pay that out of pocket anyway. But if I wanted to go take care of a deviated septum or something, I can't pay extra for that if I want particular health care. There is a provision in here for retirees. So if you're a retiree, you're on the insurance, on the New York Health Cares Act insurance or the New York Health Cares Act plan. If you move out of state and you were a public employee that had benefits, your benefits will then be available again. So let's say you move to Florida because you've had it with New York, your benefits are then available. So there's been other senators. New York State Senator Patrick Gallivan has estimated taking the RAND numbers and putting them into our 2022 dollars, not our 2024 dollars, that it would cost $160 billion in the first year. RAND has said that this would cost 2018 dollars, 139 billion in the first year, and 156% increase over projected state tax revenue in the status quo. So they're taking 2018. Now remember, our taxes have gone up a lot since 2018. So they're taking the 2018 revenue and they're saying this will be 156% more. So that's whatever the tax was, whatever your tax was in 2018, add 100 and then add 50% more to that. So let's say you paid $10,000 in state tax in 2018. If we're going to figure out how this works, you've got a taxable income growth then of $25,000. So now you're paying $25,000 versus the 10. But you know what? You're not going to have to pay healthcare benefits. I know people are going to turn around and say, well, look, your employer's paying some, there's other revenue coming in. It's estimated that taxes will go, which is we're at currently, I think, a 6% tax rate, that they'll need to go on a sliding scale up to 16% to cover this bill. It's a massive bill. It's not been tried anywhere. People want to talk about the National Health Service in Great Britain. Well, the National Health Service, you're allowed to have private insurance. They compare this to European single payer. There is no European single payer. All the European countries are able to have private insurance. And why are they able to have private insurance? Because the wait times are so long. You wait for a doctor, you wait for an appointment, you wait in an emergency room. I know we do that now. It's not the best healthcare coverage plan, but I don't believe the answer is having New York State take over the healthcare plan. So there's a little, let's finish the RAND report. New York Healthcare Act would require large shifts in the types of payments people make for healthcare. Tax payments would replace premiums, out-of-pocket expenses. So if you had a good bargaining unit, let's say you're in a union, and they said, all right, we don't want a 3% raise this year. We'll take a 2.5% raise, but we want better healthcare. Well, that benefit that you got by giving up that 0.5% raise, that goes away. After redirection of federal and healthcare outlays to New York, the additional tax revenue needed to finance the program in 2022 would be $139 billion. We already spoke about that. No guarantee that we don't get those revenues from the U.S. government. With New York health taxes, that scale of income for payments for healthcare could decline substantially among lower income residents and rise substantially among higher income residents. Now, I will say this, one of the benefits I think that we have with our current healthcare system, I go to the doctor, I have a copay. My copay happens to be $50. So if I want to wait it out a little bit because I don't want to spend that $50, I think that's all fair. Again, I can afford $50, but maybe I don't want to go all the time. It's a deterrent to have to lay out some money. That's how capitalist society works. Under this plan, you just go. How many doctors stay in business? How many doctors stay in New York? We all talk about the ramifications of bail reform and lower the age. Well, what ramifications happen here? I did ask. There was Peter Arnow was listed as an economist at this. I believe he works for Amherst, University of Amherst. He said he's done some studies and there's savings involved. I asked if those studies were dynamic or static. He said, well, they're static. You have to start somewhere. Static, one variable. So that means that we're not taking into account as we add all these people onto the rolls, how much it goes up. Again, remember, 160 billion is the first year. Once people start coming in, once people come into New York State, just maybe for the healthcare, where do those taxes go and what does that do in then driving folks out of the state? Our higher taxes, remember, New York is one of the states where people are fleeing. Those higher income individuals are saying, I don't want to pay the tax. I can do some of my work in Florida where there are no state taxes, Texas, Nevada, or Pennsylvania, and not pay state tax and not have to pay for somebody else's health care. So again, I'm not the expert in this. The bill has been on the books in some form or another since 1992. The difference in this bill is it offers retraining for health insurance employees. Remember, health insurance employees will no longer be employed because there will be no health insurance employees in New York State. So they have offered training. I believe the bill offers 2 years of unemployment benefits with training. You have to prove that you are retraining. So those are all expenses added onto here that are not worked into the RAND Corporation analysis. There's costs for that retraining. There's costs for the unemployment benefits. Let's see what else we have in here. There were also some negotiations with unions. I believe the nurses union is behind this. There's a couple of other, but there are many other unions who are not in favor of this because they spent valuable negotiation time negotiating for benefits versus salary. So they haven't gotten all the unions on board. Again, there's no guarantee this passes. There are some sponsors in our area to this bill. Nader Sage, who's running for assembly in the 90th district. I believe he has an opponent, John Isaac. So I would encourage you to email Assemblyman Sage and tell him whether or not you support this bill. I think that may make a determination into his further support. Shelley Mayer is also running this year for state senate. She's a sponsor of the bill. I encourage you to email Shelley Mayer, State Senator Shelley Mayer, and let her know. Andrea Stewart Cousins is not signed on as a sponsor of the bill, but Gary Pretlow is. Gary Pretlow is in the 88th. I don't believe he's got an opponent. I believe Shelley has an opponent. I don't recall her name. I believe it's a woman who's running against Shelley, a woman from Rye. But I encourage you to reach out if you're in favor or reach out if you're opposed. Look, there were a lot of people at this meeting who were in favor of it. Um, there are a lot of people like me who are not in favor of change and not in favor of the government taking over that large a portion of our healthcare. Look, they said you can keep your provider. We were told that under Obamacare, we can keep our provider, but many of the providers didn't stay. They didn't stay in business. My doctor went and joined Northwell Health because he couldn't stay in business after the provisions. So again, static models only talk about one variable. Dynamic models start talking about how many doctors go away, how many more people come on the system, how much more this is cost, and we are adding 100, what was that? 152%, 156% increase to the tax load. We already went substantially. I paid a lot more last year than I've paid in previous years. And frankly, this would make New York State unlivable for me. So I urge you to email your senators, your state assembly folks. This is a state bill. It's not a federal bill. Let them know how you feel. You might be in favor of it. You might not. Um, I wish I had some better information for you. Um, Very convoluted bill to read through. Uh, I was also going to talk about the 5.5%, 5.51% increase on the Yonkers budget. It's the Yonkers executive budget. It's not adopted yet. I'll talk about that in the next podcast. I want to give it its own due. I believe that before we can break the tax cap, which this does, the council has to have hearings, and they're coming up next week. Please check the website if you want to speak at those hearings. They need 5 of 7 of the council folks to vote. The council members need a majority. I believe, you know, they probably have that to break the tax cap. And then there are a couple other things going into breaking the tax cap. It's a 2% tax cap, but worked into that 2% tax cap to get last year's carryover, which might be a 0.5%, carry forward rather, so they can carry forward whatever they didn't break last year. Exempt from breaking the tax cap is pension, pension benefits, healthcare benefits, and any current lawsuits. So any of the raises due to pension benefits, current lawsuits, or the carry forward is what they get. So I encourage you to speak out about that. Look, I get it. The mayor's between a rock and a hard place. Healthcare costs have gone up. He's got to cover that. I think he's adding 5 positions. Somewhere I read that he's taking 10 off, but the count is 5 higher than last year in his budget document. I'll break that down a little bit, where those 5 positions are, and I'll try to find where his 10 position savings through attrition is. Um, so it's about $32 million he's adding to the budget this year. We all knew this was coming. We were running on COVID funds. Okay. We had some free money for a while. The free money is gone. So that'll be next week's podcast. I won't do regular podcasts, but I will do podcasts when we have topics that are worth discussing. So thanks for listening, and see you next week.